Hey everyone, so we are continuing with blood and this is almost the last edition of it. Now in this we are going to talk about the WBCs and we are also going to talk about the platelets. Firstly, when we'll start talking about the disorders of the WBCs, we are going to talk about agranulocytosis. And agranulocytosis means that granulocytes somewhere are lacking, and that's why this condition is also called as granulocytopenia. Now in granulocytopenia, it is of two types. We can see it is of primary and it is of secondary. And the primary cause here of granulocytopenia is unknown and we still do not know what is the cause of it exactly. If we talk about the secondary one here, then the cause basically is recognized. And if we talk about the cause here, then the cause of secondary can be because of multiple conditions which we can acronym as MAP. So these are certain drugs and these drugs can be remembered by an acronym which is called as MAP. M basically signifies macrolides, okay. M is for macrolides and A we have here for anti-thyroid drugs, and P here is for procainamide. So these are the drugs which can, when you give these drugs, sometimes can result in the conditions of agranulocytosis. At least we know the cause specifically here. And sometimes what happens is, out of the granulocytes, now we obviously know the granulocytes, they are the neutrophils, they are the eosinophils and they are the basophils. So the neutrophils specifically govern the overall count of the granulocytes, and sometimes specifically the count of neutrophils goes down. Whenever the count of neutrophils goes down, then that condition is called as neutropenia. In fact, when do we call the condition as neutropenia? When the neutrophil levels are below 1500 per millimeter cube. Okay, then we will call the condition as neutropenia. Now sometimes these conditions of neutropenia can be associated with certain conditions of infancy. Okay, so what are the conditions of infancy where the problem of neutropenia is going to arise? We have a plethora of conditions here, and this is Shwachman-Diamond syndrome. Yeah, a complicated name here. It is Shwachman-Diamond syndrome. So this can result in neutropenias. Then we have dyskeratosis congenita. Okay, this is dyskeratosis congenita, as it's a congenital condition, so the name is dyskeratosis congenita. Okay, the other is cartilage hair syndrome. Cartilage hair syndrome, and the other one is severe congenital neutropenia. Severe congenital neutropenia. So these are the conditions which we have to remember, and these are the conditions which are in infancy and can result in neutropenic conditions. Now sometimes neutropenia can be detected later on in life. That means they are not detected in infancy, but it can be detected later in life, and this can be due to certain conditions like leukemia, Gaucher's disease. Okay, we have leukemia. So in leukemia, what actually happens is, let's say this is the bone marrow house and all the cells are living here. We have the cells which are present, the precursor cells for synthesizing the RBCs, and we have these precursor cells for synthesizing the WBCs. In fact, we will have these precursor cells living in this house which are responsible for synthesizing the platelets as well. But the point is, in leukemic conditions, leukemic cells infiltrate the bone marrow and they kick out and kill all of these precursor cells. Now nothing is going to be formed. Neither the RBCs are going to be formed, neither the WBCs are going to be formed, and neither the platelet cells are going to be formed. Only the leukemic cells will thrive and they will say, I am going to live here. Everybody get lost. Okay, something like that. So here what happens, see, the neutrophils will also be reduced in count, and because of leukemia you can have the conditions of neutropenia. This is also seen in Gaucher's disease and this is also seen in conditions of osteopetrosis. Now these conditions which I have mentioned, the three of them here, are seen in later life and should not be confused with the conditions of infancy. Okay, they should not be confused with the conditions of infancy. So what we are seeing is that multiple plethora of conditions here can be a cause of neutropenia. In fact, what happens is there are more drugs here which can result in neutropenia. The basic drugs, we can remember it by the acronym which was MAP. Then you have certain anti-cancer agents. Anti-cancer agents like nitrogen mustards, busulfan, I will write here. These are anti-cancer agents. Okay, so anti-cancer agents, and what we'll do is, okay, we will, first of all, we will take, okay, the board up so that we can write the anti-cancer agents. And the anti-cancer agents can be nitrogen mustards. These can be nitrogen mustards, and this can be busulfan. Okay, what else is here? Then we can have chlorambucil and cyclophosphamide. Okay, chlorambucil, and we can have cyclophosphamide. So these are the anti-cancer agents which can also suppress the neutrophil counts. Certain antibiotics like penicillins and sulfonamides can do the same. Certain antibiotics or antimicrobial agents, and these are penicillins, and they can be sulfonamides as well, which can result in neutropenia. So we are seeing multiple conditions here causing neutropenia. Cannot explain you because it's not a concept. You'll have to write it in your by heart copy. Okay, then we have certain viral infections which can cause neutropenia as well. Viral infections, now what are these? These can be your hepatitis A, they can be hepatitis B as well. Plus there are other viral infections like rubella, measles, varicella. Rubella, okay, we have measles as well, and we have varicella as well. Plus there is another virus which is called as respiratory syncytial virus. You can write it as RSV, and how can we forget the HIV virus, which can do the same and suppress the neutrophil counts. In fact, you remember folate and B12 were also playing in the role of division of these cells. So neutrophils are rapidly dividing cells, and they would require folate and B12 as well for their growth, and because of their deficiency, neutropenia can also occur. So we basically find that there are plethora of causes which can result in neutropenia. In fact, when the neutrophil counts go down, what can be the oral features which can be appreciated? When the neutrophils are going down, then the oral cavity specifically has a propensity to fight off lesser infections. And here we see that we have necrotizing ulcerations of the oral mucosa. Okay, can we see here? Obviously, yes, we can see these areas of necrosis which are developing here in the oral mucosa, and this shows that the neutrophils cannot ward off or fight off the infections in the oral cavity, and this can also be seen in the parts of the pharynx, and they can also be seen here in the gingiva. You can see this boggy gingiva resulting in gingivitis, because here also the neutrophils are less, so the microorganisms, the other organisms of the oral cavity take over and they start destroying these oral tissues. In fact, sometimes there can be ragged necrotic ulcers also, and these ulcers can be mistaken with carcinomas. But these ulcers are not because of carcinomas here, they are because of the suppressed levels of the neutrophils which are going down, and sometimes they might be covered by gray-black membranes as well. So then we have another very interesting form of neutropenia, which is a cyclic event, and this is called as cyclic neutropenia. So in cyclic neutropenia, what happens is, let's say these are the neutrophil counts. So the neutrophils arise, and then what happens, over a period of 21 days, they will go down, then they will rise to normal again, and then they will go down. So this whole period of cycle, basically going up and down, takes about approximately 21 days. This is almost the same as 3 weeks. And in 3 weeks, we can appreciate the counts going up, going to the normal, and then depleting again. And this follows a cyclic trend. And since it is following a cyclic trend, these neutrophil counts, the condition is called as cyclic neutropenia. Here there is a genetic problem related with a gene which is called as ELANE, or sometimes it is also mentioned as the ELA2 gene. So we have to remember here that certain genes play a role when cyclic neutropenia is happening about. And this basically happens because the bone marrow is arrested for a certain period of time. It is not able to produce the cells, and because of this, this cyclic condition happens, and the cycle is generally seen in young adults and children as well, and the cyclic trend is for 3 weeks, which is approximately the same as that of 21 days. So next what we are going to do is, we are going to talk about leukemias. And when we are going to talk about leukemias, it will not be in detail here because it has been a part of general medicine. Now general medicine, there is a folder of general medicine in your app, and when you go there, there is a section of hemato-oncology. In hemato-oncology, there is a beautiful introduction of leukemia and subsequent all the chapters of leukemias, the lymphomas, the plasma cell disorders are in detail, highlighting the concepts behind these. Now those are micro lectures which will give you a brief summary. Those lectures live would be a part of general medicine. So if you want to go into the detail of these disorders, and I would suggest if only time permits, then only go there, okay? Then you can take a look at those micro lectures of these blood disorders and especially the hemato-oncology, and it will give you a guided aspect into all the diseases. Here in oral pathology, we will generally try to cover the oral aspects of leukemias or anything which is a little separate here, which I find interesting. So if we talk about leukemias, they basically represent a set of malignancies of the hematopoietic stem cell deviation, and these can be classified according to the clinical course. They can be classified as acute, and they can be classified as chronic. Now the acute, depending upon their lineage, they can be either called as myeloid lineage or they can be referred to as lymphoid lineage, and this described is AML, and same ways we'll have ALL. And then the chronic cases also according to their cellular lineages could be myeloid and lymphoid, and this results in CML and it would result in CLL. Now there is an introduction of leukemia in this hemato-oncology of general medicine. Just go there and take a look. You will realize how the lineages are differentiated and how the acute form from the chronic form differs. Okay, now what happens is there are certain syndromes also which have a predisposition of developing these cancers, and for this For developing leukemias, I have developed those genetic disorders as an acronym, which is few sink bad. That means these people are going to sink badly because they are going to suffer from leukemias. So we have made an acronym of these disorders, which is few sink bad. What is FE? FE basically stands for Fanconi's anemia. Okay, F here is for Fanconi's anemia. Okay, what is the W here? The W is the Wiskott-Aldrich syndrome. That's the second one here. SI here stands for Schwackman syndrome. Okay, this is Schwackman syndrome. Okay, next is N here, and this signifies neurofibromatosis. This we will cover elaborately in oral pathology when I will talk about neoplasia in detail. Then we would take a look into detail what is the mechanism, what are the genes, and how it is playing along. Okay, K is for Klinefelter's syndrome. Okay, then we have these chromosomal aberration disorders. B is for Bloom syndrome. A is for ataxia telangiectasia, and we have D, which signifies Down syndrome. And this completes our acronym, which is few sink bad. F is for Fanconi, W is for Wiskott-Aldrich, S is for Schwackman syndrome, N is for neurofibromatosis, K Klinefelter, B Bloom, A ataxia telangiectasia, and D Down's syndrome. Okay, so these are the syndromes which we should actually by heart, because they give MCQs pertaining to this, and they will ask all the following are genetic conditions associated with leukemias, except they will give these three and some other fourth condition, and then you're going to confuse a little bit, isn't it? Okay, next if we talk about these AML, ALL, CLL, CML. So AML, if we talk about the clinical features and age groups which it is affecting, AML basically affects broader age groups. Okay, so there is no specific criteria where this is going to affect. Right. Next, when we'll take a look at ALL here, ALL affects children more. Always remember, they ask which leukemia affects children more, and you will remember all is for children. All is not for everybody, but all is for children. If we talk about CML, CML here peaks during the 3rd to 4th decades of life. Okay, this peaks during the 3rd to 4th decade of life. And the CLL basically is a disease of the elderly, and this primarily affects the elderly and older population. Now, if we talk about CML here, then there is a very interesting chromosomal mutation here at the CML, and here we have a translocation here. Some part of, we have two chromosomes here, which is chromosome number 9 and chromosome number 22. Some part of chromosome number 9 and 22 break away and it attaches here. Okay, 9 breaks, and this is called as T22-9 translocation. Okay, in fact it is written as T922 translocation, and this translocation, when some part of chromosome number 9 attaches to chromosome number 22, is called as Philadelphia translocation. Okay, Philadelphia translocation, right? So Philadelphia translocation is a part of CML, and it has been asked time and again in multiple MCQs. Okay, so now if we talk about AML here, okay, AML you see was affecting the broader age groups, and AML is a group of disorder that appears to represent the early stages which are associated with myelodysplasia syndrome, and these cancers basically replace the normal stem cells, and cancer cells are prevalent there, resulting in anemia also. When these AML cells reach the bone marrow, they will kick out all the other cells and they will say, no, nobody will live, we will live here. And they will result in anemia. And this specific anemia is called as myelophthic anemia. Okay, what is this anemia called? This anemia would be called as myelophthic anemia. Okay, now there are certain variants here which we wanted to talk about. Okay, when we'll talk about the variants here, we are going to talk about granulocytic sarcoma, and granulocytic sarcoma is also called as extramedullary myeloid tumor. Extramedullary myeloid tumor. What do we mean by that? I'll just show you. See, what happens, this was the bone marrow house, and this is where the cells which were supposed to synthesize the RBCs, this is where the WBCs were supposed to synthesize, and this was the place where platelets also were supposed to synthesize. Now here what happens, these bad leukemic cells, they say we are going to infiltrate the bone marrow, we are going to kill all of these lineages, and we are going to live. And they start living in this house which is called as the bone marrow house. But then what happens, they overpopulate this house. When these overpopulate this house, now these cells, they start flowing into the circulation as well. Now when these move into the circulation, they can go into peripheral regions as well. See, they are all unhappy buggers who are now going into the circulation. In fact, that is where they come out of the bone marrow. When they come out of the bone marrow, we use the terminology which is called as extramedullary, because it has come out and it's a myeloid tumor. Sometimes it can even settle in the gingiva. We can see these boggy swellings. Of course, yes, you can see these boggy swellings which are highlighted here, and you're seeing here that these tumors have settled in the gingiva. And sometimes what happens, so many tumorous growths are there in the gingiva, these start infiltrating the gingiva, and that the gingiva generally appears greenish in color. Okay, greenish in color. Now, when in fact, it can also reach to other soft tissues and start appearing greenish in color. These cells, these leukemic cells, have a slight greenish tinge. And because of the green color, it can be correlated with a term which is called as chlor. Chlor means green and oma is tumor. So this is also called as chloroma when these sort of tumors form extramedullary colonies and they start settling in peripheral soft tissues where they appear greener in color. Look at this gingiva. It might appear slightly blackish to you, but yes, if you look closely, you will find these greenish hue in this gingiva as well. And that means the tumor cells have settled nicely here and have started to grow. In fact, you can take a look here. In the palate as well, it has locally settled and these tumorous cells are locally growing in the palatal region as well. And that is why these are called as granulocytic sarcomas, also called as extramedullary myeloid tumors, because they have come out of the bone marrow. So what happens? They generally appear greenish in color and generally they are of the myeloid origin. You remember the AML or the CML? Yes, they are of the myelomonocytic types of leukemia. Okay, then we'll talk about another variant here, and this is called as mycosis fungoides. Mycosis fungoides. Now, don't you think this is a misnomer actually? We are talking about leukemia and we're talking about mycosis fungoides. Mycosis and fungoides both actually mean a fungal infection. So in older times, what happens, it was detected as if there was this fungal growth on the skin. But this was, the diagnosis was confused because they thought it was a fungal infection. It was looking like a fungal infection on the skin, but it actually was not a fungal infection. In fact, this basically is a cutaneous lymphoma happening over the surface of the skin. And that is why this is called as cutaneous T-cell lymphoma. Okay, what is this called? It is called as a cutaneous T cell lymphoma. Why cutaneous? Because it is happening on the cutaneous tissue which is around the skin region. Okay, right? And this lymphoma is derived from T lymphocytes, and that is why you have the word T which is mentioned here. So this is derived from the T lymphocytes, specifically the CD4 positive T helper cells. Okay, which ones? Specifically the CD4 positive T helper cells play a role here, and this condition exhibits a very peculiar property as well, and this property is called as epidermiotropism. Epidermiotropism. And I have told you, whenever you do not understand a word, just split the word. Epidermiotropism. At least we understand the word epidermio is derived from the word epidermis. So what is happening here is that these cancers have a propensity to invade the epidermis. Okay, for example, I'll show you a slide later on, and what happens that these tumors go from beneath the connective tissue and they start invading and settling down in the superficial layers of the epidermis, and this is how they start growing in the epidermis. They mimic fungal infections. You give antifungals, you will not be able to treat them, and that is why the name has been derived, which is mycosis fungoides. Now, if we talk about the spread of the disease fashion, male is to female ratio is 2:1. Male is to female ratio is 2:1. That means it affects 2 men and 1 female. Now, this cancer actually happens in stages. The first stage is called as, okay, I'll write the stages here. Okay, so the first stage is called as the eczematous stage. Eczematous. Eczema basically is a red rash on the surface of the skin, and this is also called as erythematous stage. So the patient would actually find a red rash on the surface of the skin, and who knows, the doctor might confuse it with the condition of eczema. Now, sometimes it is often mistaken for psoriasis as well, because it is growing on the extensor surfaces. Now, do you know what is the flexor surface and what is the extensor surface? Extensor are the outside surfaces and the flexor are these inside surfaces. Flexor surfaces, if we'll talk in detail about skin disorders, I'm not talking about now flexor details. Flexor problem would be with lichen planus, and extensor generally is associated with psoriasis. So these cancers also affect these outside surfaces mainly, which are the extensor surfaces, and that is why they can be confused with psoriasis. So now what happens, this is the first stage, which is, okay, let me draw this skin here, and on the skin what we'll do is we have this red patch or red rash. And now over a period of time, what happens is this red patch or red rash starts to grow. They become elevated. Initially they were flat. And now when they start to grow, we have the second stage here, which is of the elevated lesions, and these are called as the plaque stage. So in plaque stage, what will happen here, those lesions which were flatter now start to get elevated. Okay, right? You find these lesions a little bit, yeah, they have elevated out, right? So as if a red whole plaquey patch is there on the surface of the skin. And these plaques, now what happens, become more and more distinct, and now they are converted into nodules. So this is the third stage, and here we find that these plaques which were elevated, these elevated plaques now are converted into nodules, and these nodules can ulcerate as well. And this basically signifies the third stage here, which is called as the tumor stage. Okay, now it looks like a tumor, and that is why this is called as a tumor stage. So what we are seeing that mycosis fungoides has 3 stages. The first stage is the eczematous stage, the second is the plaque stage, and the third, which we are taking a look at, is the tumor stage. Now sometimes what happens that a very aggressive form of this disease happens. Normally what happens, mycosis fungoides spreads slowly and slowly. Slowly it will travel through these stages, which are the exematous, the plaque and the tumor stage. But sometimes what happens, it grows very, very aggressively on the surface of the skin, and very, very rapidly it starts to grow on the surface of the skin. This aggressive expression is called as Sézary syndrome. Okay, let me just write it. Whenever we have this very aggressive growth of this lesion, then this is called as Sézary syndrome. Okay, so we should not confuse the normal Sézary syndrome, the abnormal Sézary syndrome, with the normal mycosis fungoides. The Sézary syndrome sometimes can resemble a dermatopathic T-cell leukemia as well, because the T-cell leukemia grows very, very rapidly. So Sézary syndrome is a very, very aggressive variant and needs to be differentiated from the normal mycosis fungoides, because the normal mycosis fungoides was slowly and slowly evolving into 3 stages. Okay, now if we take a look at the histopathologic slide here, which I wanted to show you here, this specifically, these features of the mycosis fungoides are mainly appreciated in the plaque stage. So in the plaque stage, what happens? You have, see, from the connective tissue area, okay, from the connective tissue area, you see these cells, right? So these cells are generally from the connective tissue traveling, and from here they start reaching the epithelium as well. In fact, you will find these multiple cells in the epithelium as well, because from the connective tissue, these cells have now invaded the epithelium, and what we see is that they have started to live here in the epithelium as well, and this is how the tumor is proliferating. So what we see is these basic abnormal cells which are moving from the connective tissue to the epithelium, these abnormal lymphocytes are also called as the mycosis cells, and these cells which are moving from the connective tissue to the epithelium are also called as Sézary cells. Okay, one and the same thing. Now, another thing which I wanted to talk about was that when these cells invade here, certain micro abscesses are also formed. Certain abscesses are formed here because of the destruction of the epithelium. And these abscesses, sometimes these abscesses are also seen in psoriasis, okay? So there would be more confusion on histopathology as well. But these cells would confirm the diagnosis, and one more thing which I'll tell you later. But first of all, what is the name of this micro abscess which is happening? These micro abscesses are called as Potrier's micro abscesses. Okay, so another thing which is seen here is, along with the Sézary cells, we have Potrier's micro abscesses, and you see, as these cells are invading, they acquire a very abnormal shape. Okay, if you take a look at the shape of these cells, they are not actually circular, they are like this. In fact, they are representing the brain with the sulci and the gyri, something like this. This is how a cell actually looks like. So these cells, they have this nucleus as well, like this, which is, you can see here, right? See this nucleus, this also looks like a brain, and this is called as cerebriform nucleus. And cerebriform nucleus is another hallmark here. Okay, cerebriform nucleus will not be seen in psoriasis. So Potrier's micro abscesses could be seen in both the conditions, which is mycosis fungoides and psoriasis. But then these cerebriform nucleus, they would only and only be appreciated in mycosis fungoides. They would never ever be a feature of psoriasis. Okay. What is the treatment for this? It's a cancer. It's actually a type of a skin cancer. And here you can treat it by topical nitrogen mustards plus Puva therapy. Okay, what can you do? You can take topical nitrogen mustards. And what else can we do? We can do Puva therapy. PUVA A therapy. Okay, what is this PUVA? This is your 8-methoxysoralen ultraviolet A. P basically stands for 8-methoxysoralen, and you have UVA, right? UVA. This is the ultraviolet A. Okay, this basically is the treatment here of the mycosis fungoides. Now, next what we are doing is we are going to talk about multiple myeloma, and multiple myeloma again is very nicely illustrated in your oncology section in general medicine. You can take a look at it. Here we will only talk about the perspective from oral pathology point of view. Now, if we talk about multiple myeloma, these are basically uncommon malignancy of the plasma cell origin. So just imagine that this is a plasma cell, and what is the plasma cell actually forming? Plasma cell, you know, is responsible for the formation of these, right? What are these? These are antibodies, right? Normally plasma cells synthesize antibodies, but here what happens, in this there are mutations happening and the plasma cells synthesizing very abnormal only one line of antibodies. When only one lineage of antibodies are synthesized, they would be called as monoclonal antibodies, because what is happening, only and only one lineage of antibodies is being synthesized in multiple myeloma. And here what happens, because these monoclonal antibodies are being synthesized in very high quantity, these generally start getting deposited in the body as protein products, because ultimately what are antibodies? They are nothing but proteins, right? So they start getting deposited as protein products in the body, and the specific signs and symptoms are because of deposition of these proteins. Now the median age for multiple myelomas for diagnosis is 60 to 70 years. Okay, it is 60 to 70 years. That means it is not a disease of the young, but it generally happens in the older population. Bone pain is also a hallmark, because the cells go into the marrow areas and start proliferating in the marrow areas. Sometimes what happens, these monoclonal antibodies, these can go to the kidney as well. Okay, right? When they go to the kidney here, certain very light chain proteins start getting out of the kidney and they are thrown out in the urine, and these light chain proteins are called as Benz-Jones proteins. Yes, so Benz-Jones proteins are a hallmark of multiple myeloma. Now the treatment basically is by alkylating agents as melphalan or cyclophosphamide. Treatment is by alkylating agents as melphalan, or you can also give cyclophosphamide. Yes, we can give these two. This is the basic treatment modality here. Now sometimes what happens, this is happening in the whole generalized body. Sometimes what happens, these tumors can be in certain localized regions, and in localized regions what happens, when the myeloma type lesions are localized, then they are called as plasmacytomas. Okay, what are they called as? They are called as plasmacytomas when they are localized in one region and there is monoclastic proliferation in some outside regions. That means those regions sometimes cannot be in the bone marrow itself. They can be outside the bone. So when these plasmacytomas, these solitary lesions located outside, sometimes in soft tissues, are called as extramedullary plasmacytomas. Why extramedullary? Now you are understanding the terminology when we had discussed the extramedullary T cell lymphomas, here you will have extramedullary plasmacytomas, because you imagine the tumor cells are not in the bone or not in the bone marrow, but outside in certain soft tissue and are isolated. For example, they are in the palate or nose area and growing here like this. Okay, so whenever these unifocal, not the generalized, but unifocal localized areas with monoclonal proliferation of plasma cells are happening in the soft tissue, they are called as extramedullary plasmacytomas. So these, okay, if we talk about multiple myeloma, where is the most common location, or which is the most common bone which is generally affected? The most common site of multiple myeloma being affected is the spine. Yes, so the spine is the most common area where we generally find this. What is the treatment? Treatment generally is by radiotherapy of multiple myeloma, and you give 4000 centigrade dosages of radiation and the patient would be hopefully better. So this actually is talking about the various types of leukemias, lymphomas and multiple myelomas. Next we are going to talk about the platelet disorders. Now, when we start talking about the platelet disorders, the first one which we are going to talk about is primary thrombocytopenia, which is called as Verhoff's disease. You would be wondering, sir is sitting on a jet plane and running along. Okay, if you want to take a detailed look at bleeding disorders, you can go to the physiology section and you will have two topics here, bleeding disorders 1 and bleeding disorders 2. Refer to both and then come back here and you will understanding this smooth sailing process. Okay, if you have not, then now is the time, go back and attend that physiology. Bleeding disorders. Now when we start talking about bleeding disorders here, we are talking about oral pathology point of view, and the first one we are going to discuss is primary thrombocytopenia. And primary thrombocytopenia is also called as Verhoff's disease. Now this basically is an autoimmune disorder, and here what happens, see, you have these platelets, and platelets generally sometimes has certain antigens, that is normal, but then sometimes what happens, your own body starts detecting these antigens and starts forming antibodies against it, and when the antibodies are formed, then for sure the platelets are going to be destroyed. And now we see that these platelets, your own body starts killing your own platelets. Okay, so this basically is an antigen antibody reaction, and because of this, spontaneous count of platelet is reduced, and because of that we have these spots on the skin. Okay, so we have these purpura or purple rashes, which are what have I written? Purpura. So these are the purple small tiny dots which are present on the surface of the skin, and they signify that micro injury of the vessels is happening, and we have these micro bleeding sites which can result in hemorrhagic lesions, especially on the surfaces of the skin. Now they can vary in size. If you have small micro bleeding points, then these are called as petechiae. Okay, what are these called? These micro points are called as petechiae. Now when they are a little bigger in size like this, they are called as purpura. Now when the purpura coalesce, they result in even bigger lesions like this, which are called as ecchymosis. So always remember, the order is petechiae smallest in size, followed by purpura, and followed by the largest ones, which are called as ecchymosis. Okay, so here what we are seeing is, we are seeing red pinpoint petechiae, or we can see some purpura here as well. And the petechiae and purpura, whenever you see, generally they are a hallmark that there is some problem with the platelets. Okay, along with this, the patient can also present with spontaneous gingival hemorrhage as well. So here we see that since your body is attacking your own platelets, the platelet count is going down. In fact, you have platelets which are less than approximately 60,000. Okay, less than 60,000 platelets is not good. In fact, what is the time which signifies the amount of platelets? It was the bleeding time. And here we find that the bleeding time generally goes up because your platelets are going down because they are being destroyed by your own body itself. So, and what happens, you will also find the tourniquet test positive here, which was signifying capillary fragility. What can you do here? You can suppress your own immune system, which is attacking your platelets. So what can you give here? What can be the treatment modality here? We can give corticosteroids. Okay, what can we give? We can give corticosteroids, and corticosteroids have, excellent prognosis along with this problem. You give this and the platelet counts slowly and steadily are coming back to normal. Okay, next what we are doing is we are talking about a condition here which is called as thrombotic thrombocytopenic purpura. Now thrombotic thrombocytopenic purpura is also called as Moscovitz disease. What is this called? It is called as Moscovitz disease, and this is a life-threatening multi-system disease of very obscure nature. But this is also immunologically mediated. Okay, right? So we have this thrombotic thrombocytopenic purpura and we find microvascular lesions, and what happens is, again, we have these antigen antibody reactions which are happening, but these are more generalized as compared to your primary thrombocytopenia. These are more generalized and these are microvascular. So smaller vessels, microvessels are being affected more, and sometimes it can also be associated with pregnancy. So most commonly this disorder is a disorder of adults, plus it is also sometimes associated with pregnancy as well. Yes, it can be associated with pregnancy as well. Okay, so if we talk about the clinical features, what is happening? Your platelets are being destroyed. When your platelets are being destroyed, you have thrombocytopenia. Yes, we'll have thrombocytopenia, and because of this antigen antibody reaction is killing the platelets, the platelet count is going down, that is resulting in thrombocytopenia. Plus, what else do we see here? In fact, we see hemolytic anemias, fever. Okay, we see hemolytic anemias, we see certain fever as well, and along with the fever, what else do we see here? We have transitory neurodysfunction and renal failure. Transitory neurological dysfunction and renal failure. So many things are happening here because of thrombotic thrombocytopenic purpura, and this is a more complicated disorder as compared to your primary thrombocytopenia, which was Verhoff's. This is having more serious effects. Okay, if we are going to the lab, what we find here is that the bleeding time is increased again, the PT, APTT are normal, and because of the hemolytic anemia, the lactate dehydrogenase level could be elevated. Okay, so this was all about this problem. Next, what we are doing is we are talking about a condition here which is called as Wiskott-Aldrich syndrome. Now, Wiskott-Aldrich syndrome is also called as hypogammaglobulinemia M. You can see hypogammaglobulinemia M. That means immunoglobulin M is being lesser synthesized here. Okay, immunoglobulin M is being lesser synthesized here. In fact, what we'll do is, how we'll remember what kind of immunoglobulins are affected here, we will write an acronym which is GAME. Okay, these are all immunoglobulins. We have IgG, IgA, IgM and IgE. Now you know that IgM is going down because of the name hypogammaglobulinemia M. Hypogammaglobulinemia M. IgM is going down. But then the neighbors are going up. the IgA will be elevated, the IgE will be elevated, and IgG generally is normal here. Okay, it's normal here. So this disease basically is commonly signifying a lesser quantity production of IgM. Now the question arises, how is it associated with platelets? Because we are discussing platelet disorders. This basically is also characterized by thrombocytopenic purpura. Okay, this is also characterized by thrombocytopenic purpura, because again here the platelets are being destroyed along with the lesser quantity of hypogammaglobulinemia M, and this purpura is specifically seen on the face. Okay, face, we have rashes on the face, redness on the face, and there is increased susceptibility to infection as well, because your main immunoglobulin, which is IgM, is going down. Okay, so next we are coming to more terminologies which are associated with platelets, and this is called as thrombocytosthenia. Okay, thrombocytosthenia is qualitative defects in platelets. Okay, what is this? It's a qualitative defect of the platelets. Okay, that means the quality is not good. The platelet count is normal. Okay, right? So we see that the platelet count is normal, but the quality is not good. Let's say there are platelets, but if the platelets will not have those hooks, which is glycoproteins 2b and 3a, then how are they going to form linkages and how will they help in clotting? Let's say it is not there. So this can result in a normal platelet count, but the quality of the platelets is defective, and the condition is called as thrombocytosthenia. Okay, so in thrombocytosthenia, we can have familial thrombocytopenia. We can have another condition which is called as familial thrombasthenia. Let me just write here familial thrombasthenia. Okay, this is another condition when we are talking about platelets, right? So what is happening here? Here the platelet count again is normal, but this is being transmitted from family to family. Okay, here also you see it was a qualitative defect. Quantity was normal in thrombocytosthenia. A part of thrombocytosthenia is familial thrombasthenia, which is happening from family to family. That means it is passing from generation to generation. And here what happens is there is the platelet count again. The platelet count is completely normal. When the platelet count is normal, then the platelets are completely okay, but then they are not working fine. What is the other name of familial thrombasthenia? It is also called as Glanzmann's disease. Okay, this is also called as Glanzmann's disease. Next, what we are doing is we are talking about thrombocythemia. And thrombocythemia is just the opposite condition. In fact, here it signifies increase in number of platelets in the circulation. Increase in the number of platelets in the circulation. So we have more amount of platelets which are, going into the circulation, but despite this you have bleeding present. We have the bleeding present despite this, because these increased amount of platelets are actually not helping. In fact, they are resulting in more and more bleeding. What is the treatment here? The treatment here is radioactive phosphorus. For thrombocythemia, when the platelets are more, you give radioactive phosphorus, and this basically tones down the platelets and reduces or gets their quantity to normal. So we've talked about these multiple platelet disorders. Next, we are going to talk about hemophilia. Now, hemophilia we've covered before in physiology. We are covering it, but quickly here. So we see that hemophilia can be described as three ways. It can either be hemophilia A, it could be hemophilia B, or it could be hemophilia C. So hemophilia A, we know, is a defect of factor 8. Okay, that's the factor 8 deficiency. Hemophilia B is factor 9 deficiency, and just flip the 9, what will you give? 11. And hemophilia C is the deficiency of factor 11. Hemophilia A, factor 8, you know, is also called as anti-hemophilic factor, right? Hemophilia B, factor B is called as, factor 9 is called as, do you remember? No, I will not tell you. Remember the acronym. French people: take coffee, look smart, and choose shoes of plain heel fashion. Do you remember C? Christmas. Okay. Right. Christmas factor, which is also called as PTC. Okay. So what we see here is about hemophilia and specifically factor 8 here. When there is factor 8 deficiency, now what happens is clotting is not going to happen properly, right? So when clotting is not going to happen properly, a lot of bleeding tends to happen. When there is a lot of bleeding tends to happen, the blood generally pools in the spaces, and a lot of blood results in the formation of a hematoma. Okay, hematoma is a hallmark of hemophilia A, and it is also a hallmark, it can be seen in hemophilia B, right? So this is where hematomas are seen. Now, generally those smaller tiny bleeding pinpoints, do you remember those petechiae, those purpura? Petechiae and purpura generally are not seen here. Whenever the examiner would mention the words petechiae and purpura, your brain should automatically be tuned towards the platelet disorders. But when we start talking about larger bleeding, bleeding into the joints, hematoma present, then your brain should significantly tick here towards the hemophilias. And this is how what happens. There is severe bleeding into the gums, you can see here, and in fact we can have pooling of the blood in the joints here. The whole joint is filled with blood, and this generally is a hallmark associated with hemophilia A, and this is also associated with hemophilia B. Okay, hemophilia C can be differentiated because in hemophilia C there will be no bleeding into the joints. Okay, we'll write hemophilia C, and there is no bleeding in the joints. That means in hemophilia C there is less severe bleeding as compared to the other two, which is A and B. Okay, if we talk about this disorder, hemophilia A and B, these generally hemophilia A and B, they are mainly X-linked recessive disorders. That means these generally are exclusively affecting the male population. In fact, there is a hereditary transmission into the royal family of Britain, and they have this bleeding problem also called as bleeder's disease. Now, because since what is happening here is that your clotting is being affected, so which time is going to be elevated? Clotting time is going to be elevated. Is bleeding time going to be elevated? No, because bleeding time was associated with the platelets. This clotting time is associated with the clotting factors, and your APTT, which is activated partial thromboplastin time, is also elevated. So these two times here are going to be elevated with hemophilia A, B and C. Okay, and what else are we seeing here? We were seeing here multiple bleeding into the joints, which could be differentiated from those disorders of the platelets. Never ever confuse. The examiner always will confuse you between the disorder of platelets, and the examiner will confuse you between these hemophilias. And hemophilias were three types: hemophilia A, hemophilia B and hemophilia C. Next, what we are doing is we are going to talk about von Willebrand disease. and this is sort of a hemophilia, and that is why it is called as pseudo hemophilia. In fact, it is not a true hemophilia, but it can look like a hemophilia. Now what happens here? This, I am drawing the von Willebrand factor, and we can see this von Willebrand factor actually is like a crown, and in this crown you see we have this factor 8. Factor 8 is being carried by von Willebrand factor. This is the von Willebrand factor. And do you imagine those people who are selling the fruits and vendors on the top of their head? Take some vegetables, buy some whatever, it is on their head. So now what is happening when these fruits and vegetables, just imagine this von Willebrand factor is carrying factor 8 on its head. When von Willebrand factor is missing, how will the factor 8 be carried on top of the head? In fact, factor 8 is let loose in the circulation, and because of this, the half-life of factor 8 drastically reduces. Okay, factor 8 was carried on top of the head by von Willebrand factor. If von Willebrand factor is lacking, then factor 8 will also not function properly. So those patients who have a deficiency of von Willebrand factor, they will also start showing the symptoms of hemophilia A, because in those patients you have factor 8 being easily destroyed, and the half-life of factor 8 is drastically reduced, and this is why you have the name which is pseudo hemophilia. Okay, this is how we have the name pseudo hemophilia. What will be present here? If we talk about bleeding time, okay, bleeding time will be normal here. If we talk about clotting time, that would be normal here, because clotting factors are indirectly affected. Okay, so but then if we talk about APTT here, okay, if we talk about APTT here, APTT, then this would be elevated. In fact, bleeding time can be elevated in certain conditions, because von Willebrand factor was also interacting with platelets. Okay, so ultimately we can see, yes, bleeding time could be normal, but most of the times it is elevated. The clotting time is normal, and APTT here, which is signifying the intrinsic pathway, is also elevated. Now this was about von Willebrand disease, and this is associated with chromosome number 12 and P region. Next we are doing is we're going to talk about multiple conditions here which are clotting factor conditions. Next, let's say this is parahemophilia. Now parahemophilia is the deficiency of factor 5. And do you remember what was factor 5 called as? It was called as proaccelerin. And you remember it was called as proaccelerin. Now when we have factor 5 deficiency, it's a clotting factor. So CT, okay, what is going to happen here? CT is going to be elevated here. Here also we find that CT is elevated. And what else do we find here? Your factor 5 generally is associated with PT. So PT is also elevated here. And along with this, your BT is normal, bleeding time, because it is not associated with platelets. Okay, that is factor 5 deficiency, which is called as parahemophilia. Next condition we are going to talk about is afibrinogenemia. Fibrin is not there. Do you remember? Fibrinogen is factor number 1. When fibrinogen is not there, how will fibrin meshwork ultimately form? So this condition is that of afibrinogenemia. Now it is very hallmark, because neither the extrinsic nor the intrinsic pathways would be coming here and no clotting would be happening. In fact, the clotting time reaches to infinite. When there is no fibrin, there is no time to measure, it reaches this much. And the PT also reaches to infinite. This is a hallmark of afibrinogenemia, that both the CT and PT reach to infinite levels. Okay, right? So Another thing which we wanted to talk about here was fibrin stabilizing factor deficiency. And as we know, fibrin stabilizing factor is factor 13. Chromosome number 6 basically is involved here. And if there is certain damage, then it can result in factor 13 deficiency. Do you remember that fibrin stabilizing factor was responsible for stabilizing and sitting of the clot? So in these conditions, the clot from the stump can break away, reflecting the problem. If we talk about a brief summary here of multiple times, we have hemophilia, von Willebrand disease, factor 5 deficiency and afibrinogenemia. We can take these times into consideration and we can quickly revise. For example, if we talk about hemophilia, we will find the APTT elevated, bleeding time is normal, we would find the clotting time elevated and PT here would be normal. Okay, now if we talk about von Willebrand disease, in von Willebrand disease, you will, what will you get? APTT in von Willebrand disease could be normal or it could be elevated. Bleeding time is generally elevated or mildly could be normal. What about CT and PT here? Okay, CT is not going to be, it is going to be normal, and PT generally is also going to be normal here. Now, if we talk about factor 5 deficiency, in factor 5 deficiency, we will have the CT which would be elevated and PT which would be elevated. What is happening in afibrinogenemia? You have the CT going to infinite and you have the PT going to infinite. So it's an important table and you should remember it because multiple permutations and combinations are being seen here, and this is how we wrap up blood. I'm still saying if you have not studied physiology, now is the time to go back and finish blood from physiology as well. And if you want more further reading and elaborative details of blood, you can go to the hemato-oncology section of general medicine and you can finish the leukemias, the lymphomas and the plasma cell disorders. And yes, if you want, that means you should study about the platelets in details, go to physiology hemat section and you would find bleeding disorder 1 and bleeding disorder 2, and then you would understand what I have talked here in detail. So finish all of it. See, from now on what you're realizing is everything here and there correlated, isn't it? So for correlation, you must have a sound base and your physiology was the base. Okay, go back to it, finish that as well and come back here, finish the blood and we will continue with other chapters.